Okay, and thank you, Julie, for doing that moderation. Okay, we have our last session. So we, as I told you, we're moving lunch to 12:30, just 15 minutes, so we have an hour. This is about measurement and health equity. And I mentioned in the beginning that we have two goals usually, raising the mean and reducing the gaps. But often, seems to me, in metrics world, we spend a lot more time on the means than on the disparity or equity metrics. And we wanted to, matter of fact, I considered doing a whole session, and maybe we'll next year on essentially on equity metrics, equity thinking. But this will be a setup for that important question. Of course, you're not going to improve the mean if you don't reduce the gaps. So that's just kind of math. So to chair this panel, we have two panelists. Steve Woolf is here. He's a professor of family medicine and population health and director of the Center for Health and Society at Virginia Commonwealth University. In 2013, he chaired the IOM and NRC important report on shorter lives, poorer health, which has been an important report for our field. So Steve, welcome, and the panelists can come on up and we'll do this session on measurement and equity.
Good morning. I thought our challenge was going to be for our panel of tackling the difficult subject of health equity, but I think the bigger challenge is that we stand in the way of lunch. So I want to make a few introductory remarks and have more slides than I have time. So when my 10 minutes runs up, we'll just pull the plug on me and we'll get started with two very interesting talks that I think we're going to be treated by. But I wanted to make some introductory remarks just to set the stage for what we're going to be talking about. The subject of how to go about measuring health inequality has been around for a long time. This work done 10 years ago asked what if we were equal, and there's a whole, we talk about how to measure health equity, there's a whole nosological debate that we could get into about what we mean by equity. How are we defining that? Do we mean equality? Do we mean equal opportunity? What do we mean by justice? And so forth. And we don't have time necessarily at this moment, but I just want to flag that issue, that's a whole question in itself. Then there's the methodologic questions about how we measure it. In this particular example, it was standardized mortality ratios. But is this notion of ratios telling us what we want to know? And by what dimensions are we measuring it? In this example, as in many discussions of equity, the immediate focus is on race and ethnicity, how our health is shaped by the color of our skin or our cultural background and so forth. But there is also attention to the social determinants of health and how equity is shaped by such factors as income or poverty. In this particular case, an analysis, these dots represent life expectancy at the county level in proportion to poverty or median household income, and you can see the distribution of counties in the United States. I want to do this shout out to our host, the California Endowment, which funded this work that we have been doing, looking at life expectancy at the census tract level here in California. And then the analysis, and I'll come back to this in a minute if time permits, is increasingly getting down to more granular levels. We talked earlier about multiple times this morning about the need for metrics that communicate well to the public. And for reasons that I don't fully understand, our work funded by the Robert Wood Johnson Foundation to map life expectancy in this schematic way in cities around the country seems to really resonate with people, even though life expectancy is, as epidemiologists, we might say a very crude metric for much more complicated health outcomes. This really does stimulate conversation. So for example, when we released the life expectancy map for New York City, the New York Times picked it up, asked for our source data, and produced this interactive graphic on their website to try to enlighten their readership about how this breaks down by neighborhoods. Let me back up to just make a general point. So we know that disparities are pervasive in the United States. We see them geographically all around. They are not new. In many ways, they are getting worse. And they have large implications. And when we talk about these health inequities, we're naturally drawn to the question of what's behind them. And if we're talking about metrics for looking at equity, we're interested in looking at metrics for understanding those root causes. So you've seen the county health ranking slide go up a couple of times now, showing you the different domains that influence health. This is a different cut at the same question, this been done by the World Health Organization, showing the many factors that shape health outcomes. And it's very busy and complicated because the subject actually is busy and complicated. But from an analytic standpoint, if we're thinking about how do we measure the drivers of health inequity, we really need to start thinking about, well, how do we look at equity across those specific domains? Those differences exist for a variety of reasons. Nothing on this slide that you don't already know, but they include classic social determinants and a variety of place-based factors. If we take some of the famous social determinants such as income and education, we live in an environment in this country where income inequality has been increasing significantly in the last few years. We know that income and health are closely related. Any number of statistics could be shown. Here's some examples showing the gradient that exists in health outcomes by income. The same can be said about education, this graph showing mortality rates by levels of education. And these relationships are huge. So we know that these are huge factors shaping the health inequalities that we're seeing. This is analysis we did some years ago trying to pose a contrast of how much of an impact this has, so showing the large bars in the back are showing you the number of lives that would be saved if everybody had the mortality rate of people with some college education. But the stubby bars in the front are the number of lives saved by biomedical advances, trying to help raise awareness about how we're really not giving enough attention to those root causes. But increasingly, our conversation is turning to the role of place. So it's not just the classic social determinants of health that exist in people's households or in their personal lives, but the measurement of equity requires us to place greater emphasis on understanding place and its influence on health outcome. But the point I want to try to emphasize here, because we all know that, is this notion of how as a society, we are also coming to appreciate more how place shapes opportunity. And we are used to thinking of this through our health lens because that's our field. We talk about health in all policies and so forth. But if we back up for a second and look at what's going on in our society, imagine a tree, if you will. I meant to make a graphic for this. And you've got this tree trunk of opportunity that exists in a place and the conditions in that place that support opportunity. And various branches come off that tree trunk, one of which is health. So one of the symptoms of good opportunity or diminished opportunity manifests itself through health. But there are other branches involving crime, social services, the environment, so on. But one of them is health. And those of us in this field go up to the edge of that tree branch and stare at it and go, we have some real problems here. But if we're going to come up with a new generation of metrics for understanding equity, maybe the question is less about how we in the health field measure health inequity and step back and ask how we as a society measure inequity in general and the opportunities for that, and then drill down to look at its manifestations in various domains. And I think that's sort of where the future is going to take us. It also is important for us to think about the role of history and historical context and learning how we can measure inequity with an awareness of that. So for example, this is a report that we did a few years ago for Baltimore, where we looked at factors affecting health disparities in various neighborhoods of Baltimore and took up the question of redlining, which was housing policies set up in the 1930s that pretty much cast the die for neighborhoods in Baltimore to go into a cycle of persistent poverty and disadvantage and unemployment and so forth. The area that lit up on our map, or on that redlining map, turns out to be the very same neighborhoods that are struggling today with problems of violence, socioeconomic challenges, and, by the way, poor health outcomes. The riots that occurred in Baltimore were in those neighborhoods, and I think the kind of visibility that Ferguson and Baltimore and other incidents around the country that are making the front pages of our news are helping, they're leading to growing unrest about unequal opportunity for residents who are born in the wrong geography or mired there, and it's opening our eyes to the need to address these root causes. And I want to say it's not just What I'm talking about is basically the socio-ecological model, is understanding that our health outcomes and our health inequities are shaped by this more complex set of factors. But someone mentioned something about temporal and longitudinal analysis. We also need to think about the life course perspective and how these things evolve over time. The historical policy example I gave evolved over a period of decades, but also these things play out in these cohorts based on the life course of individuals. So Freddie Gray, the arrest that actually set off these riots, I don't know how many of you heard about his story, but it didn't begin with his arrest. It began as an infant, where he was in a house with extremely high levels of lead exposure. So he was getting income, and part of his context of his arrest was that he was getting income from an award settlement because of exposure to lead. But set aside that detail, the point is, here you have an example of how an infant exposed, I think his lead level was something like 50, and this was documented during infancy. And then he went on to have behavioral problems and so forth, and then you get to this incident. Understanding this larger ecological context from a life course perspective helps us think, well, when we talk about how to measure inequity, we have to learn how to measure those kinds of temporal patterns as well, and focus it on the policy implications of where we need to go with that. We have measures like the county health rankings that show us, in this particular example in Kentucky, that this particular eastern section of Kentucky, which is the area of the coal fields, has very poor health outcomes. We also know that there is persistent poverty in those areas, along with other social disadvantages. That stuff we can recite chapter and verse, but increasingly we have to become sociologists and political scientists as well to understand that those economic conditions exist because of policy and economic choices made years ago about the coal industry and so forth that set off into motion this pattern. And if we're going to close the gap, then we need to have policies addressing that. This again showing the role of childhood and adverse childhood experiences that we know lead to these particular problems. So we need to have metrics for measuring these adverse exposures that face our children. The policy implications of this, and we've talked a lot this morning about how we need to have purpose-built thinking about how we address this. And I love Steve Teutsch's notion of the logic model that he presented earlier this morning. Is that when I pull my plug? Okay. So I'll just to finish the sentence, the notion that he presented that if we have a logic model that tells us what factors are responsible for driving these, for example, inadequate investment in social policy shown in this work by Elizabeth Bradley, then we can end up setting indicators and metrics for setting policy priorities and seeing how far we're getting in addressing those root causes that the logic model tells us are responsible for our outcomes. So now that my plug is pulled, let me turn to introducing our great speakers, who I'm sure are going to get into the nuances of this in more detail. We have two distinguished individuals on this panel. Biosketches are in your meeting materials, and we ask that you hold your questions and comments until they've both made their presentations, and then we'll hopefully have some time at the end to raise those. I'm really delighted to introduce Tom Leviste, who's an old colleague. He's a professor and director of the Health Center on Health Disparity Solutions at Johns Hopkins University, and a member of the Roundtable on Population Health. And he will be followed by Sarah Truhaft, who's the Director of Equitable Growth Initiatives at Policy Link here in Oakland. So without further ado, Tom.